Hey guys, so this is part 2 of 3 for the final exam review stuff. So I'll be starting on page 177, and that's the 9 common ligaments of the spine. So moving along. Definitely you want to know that when we're talking about the 9 common ligaments, that's going to be referring to segments between C2 to L5. And then you want to know where these ligaments are found. So the intervertebral disc, the ALL, and the PLL are all going to be related to the vertebral bodies. And then you've got your leg flavum, which is going to be related to the vertebral arch. And then all the rest of those are at the apophyseal junction. So the capsular ligament, the interspinous ligament, the ligamentum nuchae, supraspinous, and intertransverse. So this is a very common question, which is what is the maximum number of common ligaments found at a vertebral couple? So there's 9 common ligaments. However, there's two of them that will not be present at the same location. So know that there's 8 would be the maximum number of the common ligaments found at a single vertebral couple. And remember, so if you had gone to lab, this would be quite clear by looking at the prosections. But the supraspinous ligament and the ligamentum nuchae are continuous with one another, and they transition at C7. So that's where below C7 is the supraspinous ligament, and above C7 it's that ligamentum nuchae. All right, then we'll talk about each of the individual ligaments. So technically, remember that intervertebral disc is one of the ligaments. Know that there are 23 true discs because there's not one between occiput and C1. There isn't one between C1 and C2 because the dens would have to poke through it. So the first disc is going to be that C2, C3 disc. And that's actually a great way to wind up counting vertebrae when you're in radiology classes. You'll notice the IVF and that disc space. And then the last true disc is going to be between L5 and the first sacral segment, because the sacrum is going to fuse, obviously, and then the coccyx fuses, so that's kind of different. You want to know all the zones, so you've got your nucleus pulposus, which is that jelly-like inner layer. You've got your annulus fibrosus, which is going to be that tough outer layer that helps to maintain the structural integrity. And then you've got your cartilaginous end plates, and those are going to be what's connected to each of the vertebral bodies and where a lot of diffusion happens. So you can see in that diagram on the right, that cartilaginous end plate is kind of the purpley thing, and that's where a lot of the blood vessels go through. So it's going to help with diffusion to get nutrients into the nucleus and the annulus, as well as diffuse out any byproducts. So yeah, you definitely just want to know which is the highly metabolic area, and that's going to be the cartilaginous end plates. So when we're talking about the health of a disc, we're typically going to be looking at in that location, because just follow the metabolism and you'll see what's going on in a segment. All right, the nucleus pulposus, remember we said that's kind of like the jelly, so some people kind of make the analogy of a jelly-filled donut. So the nucleus on the inside is going to be really squishy, liquidy. You definitely want to know, so again, that embryology connection, that it's going to be derived from the notochord and the type of collagen. So it's type 2 collagen. And I think a good way to remember which type of collagen is there is that if you remember that type 1 is really common in bone and other really tough structures that are designed for their strength and stability, type 2 is not. So if it's a jelly type texture, it's about as far from bone as it can be. So type 2 is going to be more of that mesh and a different structure than your collagen type 1. So know that nucleus pulposus is type 2, and the stronger parts are going to be type 1. We'll talk about that later. And then water percentages. So these are actually numbers that you do need to know, and he will test you on them, but it's pretty straightforward. So you kind of need to know the bookends, and you'll go from there. So in the lumbar region, we'll talk about this one primarily. At birth, the nucleus pulposus is going to be mostly water, so 88% water at birth. And then as you age, that's going to decrease over time. So it's going to decrease to about 70% after 30. So those are the two numbers that you want to know. You want to know 88% at birth, 70% after 30. And it kind of makes sense. Think of, when you're first born, there isn't a lot of pressure on those lumbar intervertebral discs, and then all that wear and tear and being walking on 2 feet, so but being biped, is going to put a lot more gravitational pressure, and over time that water is just going to be driven out of the lumbar nucleus pulposus, and it's common for the water content to decrease with age. Moving on to the annulus. So remember how we said that the annulus was that really strong structural support that's on the outside of the nucleus pulposus. So this is going to be what maintains that structural integrity of your intervertebral disc. Therefore, it makes sense that it has collagen type 1. Remember, type 1 is the strong stuff. It's found in bone and other locations where structural integrity is super important. The other thing you want to know about that collagen is it's not just present, it's also in this spiral, counter spiral. I'm like it's a little bit redundant. Spiral, counter spiral, spiral. And that's the orientation of the fibers. So the best way I had this described to me was it's kind of like a finger trap. So if you think of the strength of a finger trap, it's maximizing the strength of each of those fibers. So your body has definitely been designed to help protect that inner nucleus and give a lot of strength to those intervertebral discs. Again, the water is going to be important here. So it's still mostly water. So even though it's super, super strong and structurally sound, it's still primarily water, about 10% less than your nucleus pulposus. So at birth, 78%, and then about 70% after 30. And then that point about there's a decrease in strength where the PLL, so the PLL is going to support those intervertebral discs, but in the lumbar region, the PLL is thinner, and it's also going to be directly behind that intervertebral disc, which is why we see more posterior and posterior lateral herniations, because there's a decrease in strength of the annulus fibrosus. And then Sharpie's fibers, so that's also important. You want to know that the Sharpie's fibers are going to be what attach the annulus directly to the vertebral bodies, but the annulus also blends with those longitudinal ligaments, so your ALL and your PLL. Cartilaginous end plates, we said that those were the regions of very high metabolic activity, so they're not designed for strength, they're designed for the ability to nourish their surrounding tissues, so they're going to have that collagen type 2 again. And then you want to know that those are going to be remnant of the embryonic epiphyseal plate. Just a nice little embryology factoid there. And then, so that last point's pretty important, and you find that in the box on page 182. So the cartilaginous end plate, as I mentioned, is super important to determine the health of the discs. So when we talk about degenerative disc disease, which is really common as people age, this is going to be one of the first locations that any evidence of degeneration or damage to the discs can be seen. So chondrocytes are going to invade this cartilaginous end plate prior to any degeneration. So that's the first step in degenerative disc disease. All right, so we've talked about all of the major players, and then we have this transitional zone. So it's between the nucleus and the annulus. So in the disc itself, that's going to be the area of maximum metabolic activity. The junction between the nucleus and the annulus is not a clean-cut border. It's kind of a it's a transition zone, so it kind of morphs into the other form. And then this transitional zone is also referred to as kind of the growth plate of that intervertebral disc, so it's always remodeling. So as we grow, this is going to be the region that is changing maximally to support the spinal column. Moving into innervation. So this is important because obviously we're going to be dealing with a lot of disc herniations and those kinds of things in practice. So we want to know where the pain is coming from and how it's related to the disc itself. So it's super important to know that only that outer 1 to 2 millimeters of the annulus is going to be innervated. So when we're talking about a very painful symptoms coming from herniations, it could be something as simple as a tiny tear in that outer annulus. And then secondly, we want to know about density and variety of receptors. So in the box on page 183, he talks about the variety and density of receptors being related to the size of the disc. So we've got our lumbar discs are going to be our largest, followed by our cervicals, and then finally our thoracics. Remember, those are thinner. We don't have nearly as much movement in the thoracic spine, so they just are not as well developed as those in the lumbar and the cervical region. So you definitely want to know the order of size. So lumbars are bigger than cervicals, are bigger than thoracics, and then the bigger the size, the bigger the variety and density of the receptors. So we already mentioned that when most of you probably already know that most disc herniations, maybe you've had one or you've probably had a family member who has one, or you've heard of them at the very least, they tend to be posterior, lateral, and those are the trickier ones because you're closer to the spinal canal. Anyways, so on the posterior side of that intervertebral disc, you want to know that the innervation comes from that recurrent meningeal nerve. So he's got a whole list of nerves there. That one's the most important. Remember that that's going to be in that epidural space. And then on the anterior or lateral side, you have the ventral primary ramus. And then laterally, you have white and gray rami communicans. So just remember, those are exactly what they sound like. So those are two different rami communicans. One of them is myelinated, so white, and one of them is unmyelinated, which is gray. Finally, on that side, you also have the paradiscal ramus communicans. Functions of the intervertebral disc. So these are important. You want to know all the functions. However, most of them are pretty intuitive. So don't worry about memorizing a list. And I'll point out the ones that are most commonly tested. So they're going to attach the vertebral bodies. Remember, that's going to happen with Sharpie's fibers. And so the collagen 1 fibers terminate as Sharpie's fibers, which go directly into the bone. That's going to provide a very, very firm and strong attachment. It's also going to provide a little cushioning and separation of the different vertebral bodies. And then we talked about the size. Remember that the lumbars are going to be greater in size than the cervicals, which are going to be greater in size than the thoracics. We also talked about this before, so shaping the spine when we were talking about the different curves in the spine. So we had in the cervical region, the intervertebral discs exclusively formed that cervical lordosis. And then in the lumbars, it was a combination of the discs and the vertebral body shapes that created the lumbar lordosis. And then in the thoracics, they were flat little pancakes, so they didn't really have much to do at all with that primary thoracic kyphosis. All right, so the intervertebral discs acts as a powerful ligament. So remember, mouthful of marbles. Remember the finger trap analogy and how strong that can be. If you've ever gotten your finger stuck in a finger trap, you will know. Then number 5, they form the anterior border of the canal and intervertebral foramen. So don't forget your IVF drawings, because those will come back on this exam because they're present on every single exam. So the intervertebral disc between the two vertebral bodies was part of that anterior boundary of the IVF. So obviously, if you have any kind of issue or disruption in that intervertebral disc, that could create some consequences for the nerves that are sitting close or traveling through the IVF. It's also going to be a shock absorber. So we've got that jelly-filled donut. So we've got that very squishy nucleus pulposus in the middle, and then we've got our super strong annulus on the outside with its finger or spiral, spiral structure, which is like the finger trap. So it's going to be bouncy and it's going to help absorb a lot of shock, because I don't think bone on bone would feel very good. And then it's going to distribute the weight. So it's going to help to stabilize everything and make sure it's all functioning correctly. But obviously that weight distribution is going to decrease with age, because you're decreasing the water content, which is very important for that. So one thing I didn't point out yet that I wanted to bring to your attention, so forming that anterior border of the spinal canal and the IVF, a common test question, and I know I've said it a couple times now, but just to reiterate, he will often ask you where the most common type of herniation will occur, and that's going to be the posterior or the posterior lateral side of the intervertebral discs. And then we talked about the nervous consequences of a disc herniation, but there's also vascular consequences. So remember that below T8, so this is on page 185, we've got that artery of Adamkiewicz. So you could have some hypoxic conditions as well. And this has come up before, but 75% of disc herniations happen below T8. So we have a plethora of things going on there. And then if he were to ever ask how a specific intervertebral disc was going to affect a nerve, know that the nerve below is going to be affected. Kind of makes sense. Think of gravity. If something's poking out, it's going to be affecting the nerve below, obviously not the nerve above. So what type of ligament is the intervertebral disc? Remember, that one's going to be an amphiarthrosis symphysis joints. Those are midline. And yeah, there you go. Oh man, everybody's favorite. So we went over embryology pretty thoroughly before the first exam. I think it was the first video I sent out to you guys. So I would maybe give that a quick review, but these are really the three heavy hitters. You want to know where things are coming from. So you've got your nucleus pulposus, which is a remnant of the notochord. You've got your annulus fibrosus, which is a remnant of the perichordal disc, or the perichordal blastema. And then remember that that intrasclerotomal fissure of von Ebner represented that future site of the intervertebral disc. So those are the three heavy hitters. I would recommend just going and maybe watching that video one more time just to give yourself a little refresher, and then you'll be good to go. Moving into the rest of the ligaments. So we're going to talk about some of the things that are normal for these ligaments and what happens when it goes wrong. So classically, the ALL is defined as going from occiput to S3. However, you can see in that little box on page 188 that newer information says that it goes from occiput down to L3, and that happens by attaching to the tendon from the crura of the diaphragm. So if you see crura of the diaphragm on your exam, we're talking about ALL. We're talking about the more conventional new definition as told by Mr. Morter. So functions. Honestly, I would never think about memorizing these functions. Just use your body as your own study guide. So your ALL is going to be on the anterior border of the vertebral bodies. So what do you think it's going to limit? So ligaments are going to limit some kind of action. So it's going to limit dorsiflexion or hyperextension. So if you're doing a back bend, that's going to be tensioning that ALL, which makes sense. So just use logic to think of these functions. And then you definitely want to know DISH. So diffuse idiopathic skeletal hyperostosis. This is typically a fill-in-the-blank question, and it is calcification of the anterior longitudinal ligament. You want to know how to spell the whole thing, not just the acronym of DISH, and you'll talk about that a lot in your dye imaging classes as well. It has an AKA of Forrester's disease, so he might use that in a multiple choice setting, but he wants you to write out the diffuse idiopathic skeletal hyperostosis because that's going to be the more common terminology that's used between professionals today. And that's accessory bone growth, so which makes sense because ligament. Okay, posterior longitudinal ligament, that is on the back side, the posterior of the vertebral bodies, and classically it's going to go from C2, well, the membrana tectoria is the continuation above C2, and then the PLL from C2 down to C3. So I want you to use your body as your study guide. How would you move your body to tension out that ligament on the back of the vertebral bodies? And that would be going into flexion. So put your chin down to your chest, and that's going to be tensioning out that posterior longitudinal ligament. It's going to be super prominent in the cervicals, which makes sense because you want a lot of protection there. And this also forms, remember the PLL forms the anterior boundary of that spinal canal. And then what can go wrong? So we've got our little samurai guy down there and a really interesting looking CT up on the top right, where you can see there's some really dramatic bony growths that are going into the spinal canal. Obviously that's a really big deal. So OPLL, or ossification of the posterior longitudinal ligament, so it's nice when the acronym just tells you exactly what's going on, happens commonly in the cervical spine because that's where the PLL is most developed. So what you're going to see there is some kind of faltering gait. You're going to have loss of hand and finger dexterity. Think of how the brachial plexus is going to be involved with that. And then it has a predilection for Japanese males, and it's often genetically linked. So you will talk a lot about DISH and OPLL in your dye imaging classes, and then I've been told it comes up a lot on boards because they won't give you anything that looks as dramatic as the one that I'm showing up on the CT on the top right, but they will give you something that has a really dramatic, like a dramatic DISH, so diffuse idiopathic skeletal hyperostosis on that ALL, and then there will be very discrete OPLL, but you can see that there's slight ossification of that posterior longitudinal ligament. That's always going to be more clinically significant because obviously DISH can have its own set of consequences, but OPLL is going to be encroaching on the spinal cord, so that's kind of a big deal. All right, the good old lig flav. We talked about this just in the last part of this chunk of lecture material. So remember, this one's going to be known as our yellow elastic ligament. So it's going to be super stretchy, super elastic. It's the best example in the spine of a yellow elastic ligament. It's going to attach from lamina to lamina, and they're paired in the lumbar spine. So that diagram on the left shows a nice orientation of all of the different ligaments, well, many of the different ligaments of the spine, and you can see exactly where the lig flav sits, and it's elastic, so it's over 80%, it retains over 80% of its elastic fibers. And again, use your body, think of what the function might be. So it's elastic, and which is going to give it a little bit of an extra boost, and it's on that posterior side behind the spinal canal. So it's going to break flexion. So if you flex your neck, so you're tensioning your PLL, and you're also going to be tensioning all of the ligaments that occur behind that. So this elastic ligament is going to help to break that flexion. And importantly is that second point, it's an early prime factor in extension. So when you're going from flexion, returning to neutral, that's what it's called, or what's being described when we call it an early prime factor in extension. And that's because of the elasticity of it. So it's that kind of snapback effect. And then what can possibly go wrong? Well, it can ossify just like the rest of them. So ossification of the ligamentum flavum, that's going to be more commonly seen in the thoracic spine or the thoracolumbar zone. And So because this goes lamina to lamina, we kind of define them a little bit differently. So it's going to start out between C2 and C3, where we have our first true lamina, and then it's going to go all the way down the spinal column to L5S1. And that's your lig flav. The good old capsular ligament. So that's going to be present at every single zygapophyseal joint. And don't forget all of the orientations of your zygapophyseal joints, and then your capsular ligament is going to provide a lot of support around there. You want to know the difference between capsular ligaments in different parts of the spine. So in your cervical and lumbar region, those are going to be kind of loose, but because there's a lot more motion, remember, in that cervical and lumbar spine. So if they were really, really short and tight, they would be primarily limiting motion. So we want to support the motion and maintain the structural integrity at the same time. So in the thoracic spine, where you don't have nearly as much movement, the capsules are going to reflect that and be short and tight. We've got two layers. We've got a superficial layer and a deep layer. So outside, the superficial layer is going to be denser, it's going to be stronger, and then on the inside, you're going to have a little bit more of that elasticity. The anterior part of the capsular ligament blends with the ligamentum flavum. So you can see on that diagram on the left where the capsular ligament sits, just in front of it will be that lig flav going from lamina to lamina. So that would make sense. Those are going to support one another. And posteriorly, it's going to be reinforced with that multifidus muscle. So remember, that's going all the way down the spine. That final point is pretty interesting, and I think it's particularly interesting to us as chiropractic students. So there's 3 spinal nerve levels that receive information from a single zygapophyseal capsular ligament. So when we're talking about areas of hyper or hypomobility, where the pain is being felt may not necessarily be where the restriction or hypermobility is being experienced. So we've got 3 different levels that could be occurring at, because that's where the nerves receive info from. So that's pretty interesting, and some food for thought as you practice. Interspinous ligaments. So just like the name says, they go between spinuses. So everything you really need to know about this is on this slide. So from C2 to C3 to L5S1, it's not super well developed in humans, particularly in the cervical and thoracic zone. But then down in the lumbars, it is developed well. So you've got 3 distinct layers in the lumbar zone only. And then each of those layers is going to blend with something else or have a specific feature of it. So the ventral interspinous ligament in the lumbar region is going to blend with that ligamentum flavum. The middle interspinous ligament in the lumbar region forms the bulk of the ligament, so that's the majority of it. And then the dorsal one blends with that deep supraspinous ligament. So what's it going to do? It's going to restrict flexion a little bit in the cervical and thoracic, if at all, because remember, it's very poorly developed, maybe a little bit more in the lumbar region, but it's also going to be a proprioceptive transducer. Remember when we were talking about all the little muscles that are very poorly developed? They are typically really, really dense with proprioceptive transducers and mechanoreceptors. So it's going to be really important in those features. All right, we're getting there, guys. I know you're probably sick of talking about ligaments right now, but we'll get through it. So the ligamentum nuchae is actually one of my favorites for really ridiculous reasons that I will explain later. But there's 2 really important parts, and these tend to be fill-in-the-blank questions. So you want to know about the different layers of the ligamentum nuchae. So first of all, it's collagenous in humans, and then it's going to be more yellow elastic in quadrupeds. And where it's located, it's going to be limiting flexion, obviously. But it is the second most elastic ligament of the spine in humans. So remember that if that lig flav wasn't an answer, your ligamentum nuchae is the second most elastic ligament in humans. Okay, here's the fill in the blank. part. He wants to know that you know the names for the superficial and the deep parts of the ligamentum nuchae. So the superficial part is also known as the funicular part, and the deep part is the lamellar part. So a fun way that someone came up to remember this was that superficial people are fun, so superficial, funicular, and deep people are lame, deep and lamellar. So you just want to be able to associate those together. And this is my favorite ligament because it's super huge on horses. It's crazy huge and very elastic. So I always remember the ligamentum nuchae that way. So if that helps you, awesome. And if it does not, I apologize and forget I ever said it. All right, just a couple more. The supraspinous ligament. That's going to be a continuation of that ligamentum nuchae below C7, remember? So those two will not be found at any place at the same time. It's the most developed in the lumbar region, which seems to be a trend if you're kind of paying attention to those features. Again, limits flexion makes perfect sense where it's located, and because it's not super well developed, it's going to be a proprioceptive transducer. You guessed it. So yeah, C7, that's going to be the transition zone between the supraspinous ligament and the ligamentum nuchae. All right, last of those 9 common ligaments, the intertransverse ligament. So, again, shockingly, this is going to be best developed in the lumbars. Important and TQ points here are that in that lumbar region, we're going to have a ventral part and a dorsal part. So the ventral part of the intertransverse ligament is going to encircle that IVF, and the dorsal part forms a septum between the anterior and posterior muscular compartments. So both of these have come up typically in multiple choice style questions before. So if he's asking which part of the intertransverse ligament could be involved in any kind of nerve entrapment, it's obviously going to be the one that's more interacting with the intervertebral foramen. So the ventral one is going to encircle the IVF. But if he's talking about a septum, and seriously, if you see that word, if he's looking for a ligament and he says septum, and this was a question on mine, so the dorsal part forms a septum. It's going to be forming a thin wall, thin separation between the anterior and posterior muscular compartments. So both of those are important points. Both of those are worth studying. You made it out of the ligaments. Okay, now we're going to talk about some of the arthrology. So the ADI, you want to know this so well. This will come up time and time again. You talk about it in pathology. You're going to talk about it in rad quality. You're going to talk about it in dye imaging. You're going to talk about it in NMS class. Like, this is just important. You're going to need to know it for your whole life, so you might as well learn it now. So the atlantodental interspace, or interval, some people call it, is going to be the space between the fovea dentis on C1 and the facet for fovea dentis on C2. So you might have to write those out. You want to know the numbers. So in adults, it's typically between 2 and 3 millimeters, and in children, it's typically about 4.5 millimeters because they haven't formed a completely osseous skeleton at that point yet. So any numbers greater than those are hugely problematic because they can signify some instability in the upper cervical spine. So you typically will have to write out atlantodental interspace. You might have multiple choice questions with the numbers. You might even have to write out the numbers, and then he might even ask you to define what the space is between. So remembering that your fovea dentis is on C1 and your facet for fovea dentis is on C2. So we might flip those around in a multiple choice style question because a lot of people still get those mixed up. So you know that, know this whole slide, know all of it forever and always. Oh, more ligaments. Okay, so that posterior atlantoaxial ligament. A lot of these ligaments are super easy when you've seen them in lab. So hopefully what you're getting in your lab classes is helping a little bit with this, and hopefully the images help a little bit. And then for your second exam, I had that chart of the continuation of ligaments superiorly to inferior. So this was involved in that as well. So your posterior atlantoaxial ligament is that ligament between your atlas and your axis. It's going to be a homologue of the ligamentum flavum. Remember, Mr. Mortar loves homologues, so definitely know that. So between atlas and axis, that's going to be your cervical spinal nerve 2. So that's going to be the IVF that it's near, and it's going to resist flexion, axial rotation, and some lateral bending. I wouldn't memorize that. Occipito-axial joints, so between axis and occiput. Remember we talked about this, how it seems to not make the most sense, but if you think of the way the den sits up in C1, of course the C2 is going to have some direct articulations with the occiput for more stability. So there's no physical osseous contact. There's no physical bone articulation between C2 and occiput, but there is ligamentous attachments. So these are the heavy hitters. You've got your apical dental ligament, which is a remnant of the notochord, and it has no functional significance. That's the one that sits right at the tippy top of the odontoid process. And then you've got your alar ligaments. So remember, ala, if you speak another language, ala means wings. So your alar ligaments are big, broad, wing-like structures that are on either side of the apical ligament. They come off the top lateral side of the dens. So those are gonna put your arms up like they're giant wings, and then try to rotate. Like, think of if those are attached to something firm, that's gonna limit the axial rotation. So that should hopefully make sense. Again, I'm a huge advocate of using your body as your own study guide. And then your membrana tectoria. So that's going to be running along that backside. It's a pretty thick continuation of the posterior longitudinal ligament, and that goes all the way up. You can see a nice example of it on that diagram on the right. Then you want to know about the two different layers of the membrana tectoria and what their functions are. So your superficial layer is going to be continuous with the dura, which makes sense because it's more superficial and off of the bone a little bit. And then the deep layer is going to be continuous with the cruciate ligament. Okay, we'll hit some of that joint motion in the next slide, but we'll quickly talk about the lumbosacral joint. So page 205 can look a little confusing right off the get-go, but I'll point out the important stuff. So we're talking about the iliolumbar ligament specifically as part of this lumbosacral joint. So that first part with the A and B points, it's kind of an old style model. So what we typically get tested on, so the old style model, there's medial and lateral, and it's lumbosacral and iliolumbar respectively. However, newer information shows that the iliolumbar ligament is actually a 5-part ligamentous complex. So you've got an anterior, superior, posterior, and inferior. So the two heavy hitters are going to be the superior iliolumbar ligament. So you want to know that that's going to be going from the TVP of L5 to the quadratus, the fascia of the quadratus lumborum, your QL. And it is also the, air quotes, iliolumbar ligament of the classic description. So the point B on that chunk of verbiage above. But if you see talk of quadratus lumborum, like, this is huge. And I'm sure most of you know how important the quadratus lumborum is in that stability and function of the spine, and can be implicated in some pain. So you want to know that that superior iliolumbar ligament is going to blend into that fascia of the quadratus lumborum. That is a very classic TQ, but he might also ask you which one is the iliolumbar ligament of the classic description. And the other one that's commonly tested on is the inferior iliolumbar ligament. So that one is the lumbosacral ligament of classic description. So that's just, I guess, putting together new information with old information. So I made this chart about joint motion. Again, use your body as your study guide when you're in these exams. You want to know where something happens the most, what the primary motion is for each of them. So when you're talking about your atlanto-occipital, flexion extension, nodding, when you were in, oh, I guess you would be in palpation class right now, but if you attended any MPI stuff, you know, you always are testing that AO joint by doing a bit of a nod, so maybe look that up. And then atlantoaxial, so with the DENS, obviously that's going to be rotation. So just go through these, use your body, try out all these motions, and see if the way that you move matches up with the way you're supposed to move. So hopefully this chart is helpful, but rather than just preaching numbers at you, I think a lot of it makes sense. Go through the motions, you'll be totally fine, and then trust yourself in the exam. So this is the chart that I brought up last exam, which is that continuation of the ligaments that on the anterior spinal canal versus the posterior spinal canal. So this is fair game, fill in the blank style question or multiple choice questions for this third exam as well. Don't forget it. And remember, you'd have to write it all out. So the sacroiliac joint, or the SI joint, this is going to be a heavy hitter as well, which makes sense because these are things that you need to know. So I don't think it's on this slide, but you want to know that there's going to be more unevenness in the facets in a male SI joint than in females. So it's going to provide a little bit more stability because it gives you some more traction. The movement is going to increase for people who are heavy, so your obese population, or women who have born multiple children, so they're carrying a lot of that weight in their abdomen, which is going to put a lot of pressure on that SI joint surface, and it's going to decrease some of that unevenness. But males have a more uneven facets, which is a good thing because it provides more stability. And then there's more stability between those two joint surfaces because you have kind of lines of fibrocartilage between the articular cartilage. So I kind of think of them as like speed bumps or a little extra traction that help distribute that weight, because that's going to be the region where you move the weight from your axial skeleton onto each of your legs. So it's going to have to help with that. All right, then we've got to hit all of the important ligaments. So what you want to know from that page 209, you want to know that the interosseous SI ligament is the strongest SI ligament, which we have talked about before. You also want to know that the dorsal rami passes between the layers of that ligament there, so it could be involved, that interosseous, super strong interosseous ligament could be involved in nerve entrapment. Obviously, you want to know that. You want to know about your sacrotuberous ligament, so that it's going to form the falciform process. Sacrospinous ligament is going to be what divides the sciatic foramen into the greater and lesser sciatic foramen. So if you're talking about conditions like sciatica, that's important to recognize, and the different blood vessels that go through there. And then your capsular ligament. So just know where it's lacking in the posterior. So you do have a capsular ligament on this joint, but it is not well developed or completely absent in the posterior surface. All right, then moving into the ribs. So I would look over the quiz questions as I mentioned before. Remember certain things about your scalene muscles. So remember that your anterior scalene is going to attach on rib 1 on that scalene tubercle. Medial scalene also attaches on rib 1. And then the posterior scalene is going to attach on rib 2 near where the serratus anterior attaches. But go over old rib stuff because this is super repetitive. And yeah, you've learned it once before. So just review that stuff. So these are the types of questions that he asks, if you remember. So true ribs versus false ribs. So 1 through 7. are true. 8 through 12 are false. They're also known as Costa Vera or Costa Spuriae, which I have in my notes. I'm not sure if he also said that to you. So I don't know, someone came up with a pretty, I think, lame, but it kind of works. Mnemonic, which is 1 through 7, you go to heaven. So if you're true ribs, 1 through 7. Surface attachments, that's going to be a different way that you can differentiate the different types of ribs. So vertebral sternal versus chondral versus just straight vertebral. So you know that those 11 and 12, those are floating ribs. Ribs 1 through 7, those true ribs attached directly to the sternum. And then 8 through 10 are going to attach to cartilage, which is going to then take them up to the sternum. So that's important to know. So again, I don't know if he asked you these types of questions on exam 2, but he would ask us to name all of the classifications for rib number 9. So you know that rib number 9 is a false rib, it's a vertebrochondral rib, and it's also a typical rib, because remember, all the typical ribs have a head, neck, tubercle, body, and a sternal end. Then we've got our atypical ribs that are 1, 2, 10, and then 10 to 12. So you would want to be able to list out every single classification of that particular rib. All right, last slide for this chunk of material. So the arthrology of the anterior thorax, I wouldn't worry too much about that. Just give it a quick read through. And then the embryology, so we've already been through this again, but you just want to remind yourself about that he cares about the primary centers versus secondary centers of ossification. So just give that a quick review. So the corpus sterni, the body of the sternum, has a single primary center. That's important. And then your xiphoid process has a single secondary center and it has no primary center. So that's going to happen, sorry, not after your 3rd year. I think it's after the 3rd decade. But anyways, your book says after the 3rd year. So that can remain cartilaginous for a long time. And then remember, your typical ribs are going to have a single primary and 3 secondary, 1 for the head, 2 for each of the tubercles. Rib 1, which is atypical, has 1 for the body and 2 secondary, 1 for the head and 1 for the tubercle. Rib 2 is going to be like your typical. And then 11 and 12, those ones are important. So there are no secondary centers of ossification for either ribs 11 or 12. So those floating ribs have a single primary center for ossification and no secondary. So that's a really, really common test question. Know that, and you'll be good to go. All right, guys, keep killing it.